welcome everybody to this afternoon's workshop. So my role is Deputy Director for Policy and Strategy in the Cancer Programme at NHS England, and I use the pronouns she and her. In terms of the National Cancer Programme, experience of care is hugely important to our work. We know that how people receive care, the processes and pathways that they go through, and how they feel about those pathways and about those engagements that they have are really important and often have a really lasting effect on somebody, even once the kind of physical elements of a cancer diagnosis have moved on and passed on. So it's really important for us to be able to understand cancer patient experience and to look at ways that we can improve it so that it is as best as it can be, as well as celebrate our successes. The Under 16 Cancer Patient Experience Survey fulfills our commitment that we made in the long-term plan to really actively seek out the views of patients under the age of 16 and their parents and carers. And of course, this was really building on the good work that happens already with the adult population and through the Adult Cancer Patient Experience Survey, but recognising that what matters in terms of experience and pathways might be very different for children and for their parents and carers. And so we set to work developing the Under 16 survey, which was the first of its kind, to really, on a national level, seek these views. And we work really closely with children as patients, their carers, NHS health professionals, cancer charities and experts to put that survey together. I think it's fair to say that we're at a relatively early stage of development of the Under 16 CPES survey, having now done both the 2020 cohort and the 2021 cohort. And this really reflects our continued endeavours to really optimise that survey as best we can, make sure that we're asking the questions that are the most important in terms of improving experience for children and their parents and carers. So in particular for 2021, we made some changes and really clarified the point of time that we were asking people to comment on in terms of their experience. And we made some other changes as well and tweaks here and there. And what this means is that it's important to think about the 2021 probably as results on standalone terms rather than comparing them to 2020, because it's not something that we feel that it's possible. There isn't that time series element. But that's not to say that we don't think there's a huge opportunity here to really look at these findings. There's a wealth of information. I use this term a lot, but I see people's contributions via the Under 16 CPES survey and indeed all the insight and feedback we do as gifts. They provide us with things that we can celebrate, and they also identify things that we need to take action on and to look at where we can make improvements. And I do think when people take part in things like Under 16 CPES, they're not necessarily thinking of themselves, but they're thinking of making sure that those who come after them have as strong and as good a positive experience of care as is possible to achieve. When it comes to what we as a National Cancer Programme do with the findings, such as those from the Under 16 Cancer Patient Experience Survey, the Cancer Improvement Collaboratives are one such mechanism that we have. And this year we have been working with a number of local partners and health services staff and people with lived experience on a number of improvement projects that are on 4 different themes that were really pulled out in the 2020 Under 16 CPES. And they cover comms and information, play, emotional support, and one other, which I must just check. So I'm going to get it right. Home comforts and facilities. That one always escapes me, forgive me. So that is a really important mechanism for actually trying to use those findings, taking that gift of feedback and making some changes to the benefit of patients and services more broadly. And we thank all of the Cancer Improvement Collaborative teams who have been working on those projects and doing so in conjunction with their kind of normal day-to-day work, as it were, and then the operational challenges that are faced in services. We also are very pleased to see that the findings of the Under Cancer Patient Experience Survey are really being noticed by the nursing directorate as a whole, and Ruth May, as Chief Nursing Officer, is overseeing some work being led on a number of different areas that are relative to children and young people with cancer diagnosis, including around food, and particularly food for parents. And we've recently had an update on that work from Kate Pye, and I'm sure that would be something good to watch grow over time and see the impact of that work. So, of course, as well as what we can do at a national level, we've also been really working with PTCs and ODGs around understanding their findings and thinking about opportunities to put improvements in place going forward. And I guess just to pull out there, it's amazing to see the range of different outputs that are available through the Under 16 Cancer Patient Experience Survey. This time round, the analytical team and colleagues at Picker and in another organisation have been working really hard. We've seen a easy read version of the report. We've got a new interactive dashboard. And there's also some other changes to how we can present results in terms of suppression, which means that I think there's even more data than we've ever had before. And while we do have to exercise some caution in some of the interpretation of those data because of perhaps things like small sample sizes, there is an absolute wealth there, and it really shouldn't stop us from thinking about what are they telling us, where can we celebrate those successes, and what do we need to do going forward. Overall, I was delighted to see that parents and carers were reporting their overall experience of their child's care at 9.01, which I think is an absolutely huge testament to NHS teams and professionals up and down the country. And thank you all for everything that you have doing to support that. And crucially, 77% of the children that were included in this survey said that they felt that they were very well cared for, which again, thank you to all of you who play such an important part in that. The Under 16s Cancer Patient Experience Survey itself is a huge endeavour, and it isn't just one person, isn't just one team. Input goes across many, and including the NHS services who play such a role in helping to secure the sample in the first place, as well as to take action on some of the findings, colleagues in our analytical team and at our stakeholder organisation. So thank you to everyone who is involved in that. I won't delve into any more of the results because we're going to be going through that now. So just wanted to say thank you once again, and I'm looking forward to a really interesting workshop this afternoon.
Thank you so much for kicking us off, Jodie. Without further ado, I'm going to hand over to Philippa and Kirsty, who are going to take us through the quantitative and qualitative feedback.
The Under 16s Cancer Patient Experience Survey measures children's experience of cancer and tumour care across England. It's run annually, and the survey respondents were all children who were under the age of 16 at the time of their care, as well as their parents or carers that we survey also. So the survey has been designed to monitor the national progress on cancer care, provide information and drive local quality improvements, assist commissioners and providers of cancer care with decisions that they have, and inform the work of relevant charities and stakeholder groups supporting children with cancer. The survey has been run by ourselves at Picker on behalf of NHS England, and it's overseen by a very active advisory group of expert stakeholders that we meet with regularly throughout and make many decisions with throughout the whole process. So in total, 13 PTCs, principal treatment centres, have been included within the survey. Looking at eligibility, so who's been included? Patients with a confirmed cancer or tumour diagnosis who received inpatient or day case care from a PTC in 2021 who were under the age of 16 at the time of their discharge were eligible to complete the survey. It was a paper questionnaire with a covering letter, and 2 reminders were posted out to parents and carers. There was also the option to complete the survey online or via telephone if they wished to do so. As well as that, we provided a free phone helpline and an email for respondents if they wish to opt out, ask questions, or wish to complete the survey over the phone. We also provide a translation service. The questions were asked about children's care during 2021, and there were 3 versions of the survey depending on the patient's age prior to fieldwork. So we had the 0 to 7 questionnaire for completion by parents and carers of children aged 0 to 7. Then there is the 8 to 11 questionnaire, which has separate sections for the children and the parent and carer to complete. And then the 12 to 15 questionnaire, which again has separate sections for the child or young person and the parent and carer to complete. The survey was open for people to complete during April to June 2022, and we're continuing to explore the inclusion of outpatients and POSCUs and how this might be possible for future iterations of the under 16 CPES survey. When we're looking at the results today, figures have been rounded to the nearest whole percent and therefore may not always equal 100%. And please note the question numbers relate to the numbering of the data tables, not the questions used on the questionnaires themselves. In order to protect the identity of respondents, suppression rules have been applied to the data. So where the total number of responses to a question is less than 11, the data for that question has been suppressed, and that's indicated with an asterisk. We also have a double suppression rule. So where the base size of any subgroup, for example, ethnic group or diagnostic group, is less than 11, the data for that group and then the next smallest subgroup are also suppressed. And we've got a full range of information on the suppression rules that have been applied, and that can be found in the technical appendix, which we link to and will be available within the slides, but can also be found on the Under 16s website. So under 16s under 16 CPES is at a relatively early point in its evolution, and we continue to learn a lot about what's working well and what might need adjusting as we go through this. So there are some noted differences between 2021 and the 2020 surveys, which have led to the analytical and insight recommendation that comparisons should not be made between the results. So in line with this, comparisons between 2021 and 2020 results are not included within the report and the trends are not shown. So there's a number of reasons for this. Feedback from the cognitive interview testing with patients identified that clarification was needed on which time period patients should be reporting on. So changes were made to the wording to accommodate this, but as these only affected this year's iteration for the 2020 and 2021 survey report might be on slightly different timescales within the patient's experience. And additionally, there are differences in response rate across the 2 years. So the reduced statistical confidence in comparisons taken together just makes it extremely difficult to disentangle the change or lack of in patient experience from the survey when completed. So looking at the response rate, out of 3,672 eligible patients and children, 960 responded to the survey, which yielded a response rate of 26%. And just having a little breakdown of the number of responses via survey mode. So with the majority of people completing the paper questionnaire, of all the respondents, 74% completed the paper survey and 26% completed the online version. We didn't actually have any phone line completions for it last year. Over half of all the completed surveys were from the 0 to 7 completed by parents' age range, with the remainder split relatively equally between the 8 to 11 and 12 to 15 surveys. And this proportionally reflects those groups invited to take the survey as well, if you look at that data on the screen. So looking at just delving into the response rate a little bit more, the response rate is further broken down in the national report, and this is done by gender, ethnicity and long-term condition. So you can see there's a similar message where 3/4 of the population were white, but more white people were in the patient sample that were invited to take part in the survey. So that's reflected in the results we have. Looking at subgroup comparisons. So subgroup comparisons allow us to explore the differences in how people experience cancer care. And the next few slides present responses to the questions asking about overall care in the survey by subgroups or respondents. Some of the groups might be quite small, so please do take caution when looking at the results for these groups. And any more information on the number of responses or subgroups can be found on the About Respondents page of the Under 16 CPES website. Also, subgroup comparisons to all survey questions can also be found in the Excel data tables, again, available on the website today. The question on overall care asked to parents was structured quite differently to that asked to children, and hence there isn't an overall score for that. So when looking at the charts, blue bars will always show the overall data, and the shades of pink present the data from each survey version and age group. And where parents and carers were asked overall how they rated their child's care or tumour care from 0, which was very poor, to 10, very good, 89% rated it as 8 or more, and it was very similar across the age groups. When children were asked overall how well they were looked after for their cancer or tumour care by healthcare staff, 77% of children reported to being looked after very well, which was higher with 79% for 12 to 15-year-olds compared with 75% for 8 to 11-year-olds. Looking at the overall questions by gender, 91% of parents or carers of boys and 87% of girls rated their overall care as 8 or more out of 10. And 77% of children reported being looked after very well for their cancer or tumour care by healthcare staff, with 81% of girls reporting this compared to 76% of boys. Overall care by ethnic group, patients from a white ethnic background were more likely to say that they were looked after very well, with 80% reporting this, compared to Asian mixed or Black respondents. And then overall care by diagnostic group, there were some difference in children's ratings of overall care by the diagnostic group, for example, those with lymphomas and reticular endothelial neoplasms. And they were more likely to say that they were looked after very well, with 86% compared to some of the other diagnostic groups. Overall care by long-term condition. So 89% of parents and carers rated the overall experience of their child's care as 8 or more out of 10. And it was very similar for parents and carers of children, 88% with and 89% without another long-term condition. 77% of children reported to being looked after very well, as we heard earlier, for their cancer or tumour by healthcare staff. And it was slightly higher for those without any long-term condition, with 79% reporting that, compared to those with another condition, which was only 73%. So overall care for children by deprivation. So children from the least deprived area, which we've based on the IMD quintile, were less likely to report being looked after very well compared to those from more deprived areas. However, data for the most deprived areas is often suppressed. So looking at referral and diagnosis, the data for each question is presented in the charts for all response options. So this does include non-applicable response options such as don't know or can't remember. The response options as don't know or can't remember are not included in the scored data, and as such, the percentages within the text accompanying the charts might not always match the percentages within the charts themselves that we're looking at. So when asked, before you were told your child needed to go to hospital about their cancer or tumour, how many times did you see a GP about the health problem caused by the cancer or tumour? 63% of parents or carers reported that their child saw a GP once or twice before they were referred to the hospital. And again, full scores and data can be found on the website for that. 80% of parents and carers felt that their child was first seen by a hospital doctor as soon as they thought was necessary. And this was lower for the 8 to 11 survey types, with only 74%, and far higher with 83% for the 0 to 7 group. When asked when you were told about your child's cancer or tumour, was the information given to you in a way that you could understand? And were you told about your cancer or tumour, was information given in a way that you could understand? 73% of parents and carers and children reported that the diagnosis was definitely given in a way that they could understand. For 8 to 11-year-olds, this was lower than the other age groups, with only 59% agreeing that the information was understandable to them. 75% of parents and carers reported that they were definitely able to find information about the child's diagnosis, and there was no difference across the different survey versions relating to this. And 57% of parents and carers felt that different hospital staff are definitely aware of their child's medical history, with 78% of parents and carers reporting that they were given clear written information about the child's treatment. So support within the hospital, just under half, 45% of the parents and carers said that their child was still receiving treatment. And of the remainder, 57% said that they definitely received enough ongoing support from the hospital after their child's treatment had finished. Decisions about care and treatment. 68% of parents and carers and children said that they're definitely involved in their child's care and treatment as much as they want to be. And parents and carers of children aged 12 to 15 were more likely to report that their child's schooling and education had been impacted by being too unwell to attend school, or poor concentration due to ill health or worries, or tiredness and fatigue caused by treatment. Looking at staff availability within the hospitals, 76% of parents and carers and children felt that their child was always able to get help from hospital staff as and when they needed it. And when we look at things for children to do in the hospital, 43% of parents and carers felt that there was definitely enough things for the child to do in the hospital. And this was lower for the children in the age 8 to 11 bracket and the 12 to 15 than the parents or carers response for children aged 0 to 7. Of those who needed it, 90% of parents and carers said that play specialist support was offered in hospital for their child, and play specialists were mentioned in the free text responses that Kirsty will be looking at and elaborating on in the next part of the session. Hospital Wi-Fi. Only 34% of parents and carers felt that the hospital Wi-Fi met the needs of them or their children when they were in hospital for their stay. And hospital food. When we asked, was there a choice of food, 52% of parents and carers 52% of parents and carers and children felt that there was definitely a choice of hospital food. When asked if it was quiet enough to sleep in a hospital, only 28% of parents and carers and children reported that it was always quiet enough for them to sleep in that environment. And looking at the bedside manner, so this slide shows some data relating to questions asked about the cancer care received at home or in school. 97% of parents or carers and children felt that nurses who came to their home or school were always friendly, and 87% of parents and carers and children reported that they always understood what the nurses visiting their home or school were saying. Looking at healthcare staff's bedside manner and trust again, 84% of parents and carers always have confidence and trust in the staff caring for their child. This was slightly lower, with 82% of parents and carers for those in the age group 8 to 11 compared to 84% for 0 to 7 and 12 to 15-year-olds. 88% of parents and carers felt that their children were always treated with respect and dignity by staff. And 82% of parents and carers felt that they were always treated with empathy and understanding by staff caring for their child. So there was neither of these had big differences by the survey type with age. 76% of parents and carers felt that the staff were always sensitive to information shared with them about whilst their child was in the room, and 86% of children felt that staff were always friendly. Looking at communication, 72% of children reported that they could always understand what staff were saying. This was higher for children aged 12 to 15 compared to those for 8 to 11. And 80% of parents and carers felt that the staff always shared information with children in a way that was appropriate. So the differences by age group showed that this was highest for parents and carers of children aged 12 to 15, and it was lowest for parents and carers of those aged 0 to 7. Again, with communication, when asked, do staff talk to you, not just your parent or carer? 75% of children reported that they felt staff always talked to them and not just their parent or carer. And if we look at comparisons by age group, we can see that this was highest for children aged 12 to 15 and lowest again for children aged 8 to 11. Looking at support, so children aged 12 to 15 were more likely to report hospital staff giving them information about how to chat to other children with cancer or a tumour than those aged 8 to 11. And we're currently running a series of cognitive interviews at the moment for the 2022 survey. And we're looking for children aged between 8 to 16 to interview in January. My colleague Caroline will be sharing a copy of the recruitment advert that we have for this. This will be available in the chat box. And if anybody is able to help with recruitment in any way for this, it would be most appreciated. I'm also going to hand over now to Kirsty from Explain, who will talk through the national qualitative results with you. And again, these are all now available on the technical reports page of the Under 16s CPES website.
Thank you, Philippa. Yes, so as Philippa says, my name is Kirsty and I am from Explain Research. I led the team that conducted the qualitative research, qualitative analysis of the free text responses on the survey. And there's a lot to go through in quite a short period of time. So sorry if it's all a little bit of a whistle-stop tour. If anybody has any questions, we're always around to answer or to give any further elaboration after the event. So next slide, please. So these are the questions that were asked at the end of the survey, and it is the responses to this which have formed the basis of the analysis. So the analysis itself produced the following key themes. Next slide, please, Philippa. Sorry, I did tell you it was going to be a bit of a, I think, so we had, I think we're missing a slide, but just to give you an overarching sense of what we found, we had 8 key themes. The basis of them all was around positivity. And I think it's really important to frame everything around the qualitative analysis on that basis. So what we'll do now is we'll start talking and explain what the positive experiences were and how they shaped. And then we'll go into the areas for development that came from people and survey respondents. And I think it's key to remember that those areas for development are the gifts, as was mentioned earlier on. So in terms of positive experiences, these were discussed in a few different ways. They framed in terms of general expressions of gratitude. So, you know, it was brilliant. Thank you very much. People also discussed specifically positive experiences with nurses and positive experience with close specialists, both of which were very important to people. They also talked about communication. So when communication worked very well, it was highlighted by people as something that was particularly key to their positive experiences of their care. Next slide, please. There was also a feeling that when we looked at the quotes, that there were particular staff attributes that people mentioned as being particularly important to them. So they talked about the importance of empathy, of a feeling of friendliness, that staff were kind, that they were helpful, and that they were professional. And these words did stand out quite clearly as parts, as attributes that help shape positive experiences. Next slide, please. So that being said, we're now going to move on to the areas for potential development. The first one is around, we grouped together people talking about negative experiences attributed to staff. And I think the first bit is around poor attitudes and behaviours. And I think it's very important to remember that these are tended to be very isolated experiences and were not characteristics of somebody's experience as a whole. But when they happened, they left a mark. So people talked about a lack of empathy, and there was also a sense that sometimes staff could be insensitive in front of children. In terms of communication, people often felt, well, people sometimes talked about feeling unheard. So when communication, as we've said, when communication went well, it was really important. But when communication started to fall down, it was also mentioned repeatedly by people as an area that left them feeling that their needs were unmet. There was also a sense that staff could potentially benefit from additional needs training when they're dealing with patients who have additional needs. Next slide, please. Thank you. So, and further theme was around access issues, and this clumps together quite a few different aspects of access. Firstly, around clinical nurse specialists, people talked about care from the CNSs falling down when they were on leave or they were absent for long-term sickness, and there was just nobody there to replace them. And there was also a sense that sometimes CNSs were overworked and unresponsive. There were also a feeling, a general impression of understaffing across hospitals that sometimes came across. And there was a sense that people did not get in, people could not access or see their named consultant enough. Thank you. Next slide. So play specialists, as we've mentioned before, play specialists were talked about particularly as people who help shape positive experiences. But there were also concerns that perhaps access to play specialists wasn't frequent enough. So in particular on evenings or weekends. Which brings me to the other point, which was that people felt that care in hospital as an inpatient during weekends and bank holidays, for example, was absent. And there was also talk about wanting to be able to access the ward directly. In particular, people would talk about if they felt that their child was running a temperature or was experiencing something that would require them to be admitted, they would have to go via A&E, which could lead to long delays in busy departments, which was unsuitable for immunocompromised children. Next slide, please. People talked about delays, and delays were talked about in a few different ways. In terms of diagnosis, there was a general concern that GPs were not taking the symptoms of a child seriously enough initially, and that there was a worry that that led to a delay in diagnosis. People also talked about when they were in hospital and when they were in care for cancer, particular incidences of delays that seemed to stand out to them. One around when you get into hospital, the delay in actually requiring getting the chemotherapy. And also in terms of procedures like blood tests, so they can talk about the frustration they experienced sometimes if they required blood tests and it was taking a 6 to 7 hour delay. So next slide, please. They also talked about delays in receiving medication. This was particularly their perception was that it was from pharmacy. So if they required medication, it could take a long time to get the medication from pharmacy. And I think importantly, there was a worry that sometimes test results weren't being given to them as quickly as they could. And there was a recognition of the sense of anxiety that waiting for these test results can cause. Next slide, please. So another slide, and I think it's kind of, you can see that communication and communication issues is something that has been raised by me in a few different ways throughout this presentation. And again, just to emphasize, when it worked well, it was really important to people. But when communication started to fall down, it was also key in shaping negative experiences. So they talked about poor communication between hospitals, and they also talked about poor communication occurring within hospitals. What this often led to was a feeling that staff didn't know the patient's history, and I think a general sense that the parent or the carer was having to act as the agent of their child's care. So it was up to them to make sure that communication took place, and it was up to them to make sure that the clinicians knew who their child was and what their history was. There was also talk about the wards itself and an introduction to wards, feeling that once you were admitted, it was actually quite scary. And if there was almost, I want to say the word induction, but in an introduction to the ward, what happened, where to go, what this room is, where this microwave is, that would have been very, very helpful for people going into what is a terrifying experience for them and their child. Next slide, please. There was also concern and talk about communication around appointments and what can happen when you're sent conflicting letters, and often a feeling that the administration around the cancer care was not as efficient as it may have been. And then there was also discussion about treatment communication. Interestingly, people wanted to have a sense of an understanding of the overall treatment plan for their child. So not just the next step, but where does that next step fit into everything that's going to happen, and why are these decisions being made? Because there was often sometimes a feeling that decisions made in regard to their child were not clear and they didn't understand why these things were happening. And there was also a concern that when there was a delay in treatment, people wanted to understand it and just to be communicated clearly about it. Next slide, please. So issues with food was quite a big theme, and it was very interesting to me to hear at the start that this is something that's being picked up, and I think it's very something that I think, having read through these quotes, that we would welcome. Food and issues with food had two broad overarching aspects. The first is shown on this slide, and it relates to the impact that it was having on the child themselves. People talked about just it being generally poor quality, but critically feeling that the quality of the food and the choice of the food was meaning that the needs of cancer patients were not being met. So they would talk about feeling that it wasn't nutritionally adequate for a child that was undergoing cancer treatment, but also talking about the way that food is provided on wards and set meal times is just not okay for a child that's undergoing chemotherapy or having steroid treatment, feels sick, feels constantly hungry, and that there needed to be some flexibility and recognition of the needs of a cancer patient. Next slide, please. So then there was also talking about the issues of food and food provision on the parents and the carers specifically. So there would talk about feeling that the patients, the parent and the carer needs were being unmet. So they were either not offered food, or even if they had been willing to pay for food from a hospital, it just wasn't something that was available to them, and that the wards did not always have adequate provision to store or heat food. And they also talked about, as a consequence, the financial impact of constantly, for quite a long period of time, having to rely on expensive takeaways or local expensive shops. And what was quite poignant was that people would quite commonly in these quotes, they would talk about themselves having to go hungry so that they'd never had to leave their child's bed. Next slide, please. And so that brings us to another very broad theme, which is around unmet needs. And this was experienced in quite a few different ways, and I'm just going to touch on them quickly now. Firstly, I think quite importantly, a sense of unmet needs in terms of aftercare and people feeling that once cancer treatment was finished, they were almost left to just at the end of a cliff, and the support that they'd had during treatment was just not there post-treatment. And there was also talk about the need to give age-specific activities and entertainment, in particular regarding younger children and those needs having been very different to teenagers. And in particular, Wi-Fi, when they've talked about poor Wi-Fi provision, it isn't just about not being able to access games or their phone. For older children, it felt that they were just, if they were able to access schoolwork, they just couldn't because the Wi-Fi was too poor. Next slide, please. So, and again, in terms of the needs varying by age, there was a sense that for older children, it was just really very, very difficult to be admitted on a ward with younger children. It just didn't meet their needs. Noise, the activities, the feeling that they were not themselves a younger child and they didn't want to be with younger children. And there were also unmet needs in regards to sleep on wards and the difficulty it is in getting a good night's sleep in the hospitals in terms of ward noise, the facilities, and noise from staff. The final slide is around wider hospital issues, because we have mentioned these. They aren't actually directly related often to cancer services and the ability of cancer services to provide care themselves, but we felt it was important to acknowledge them because obviously perceptions of care are not isolated. So people sometimes talked about the wards themselves and the lack of hygiene and cleanliness on the wards. And there was discussion within the presentation around COVID-19 and the impact of COVID-19 on visitor numbers and sometimes facilities being closed. Notably, that was far less than in the previous survey, but it was still mentioned on occasion. And I think it's important to acknowledge that this work was still carried out during those times.
Thank you so much, Kirsty, Philippa. We are also joined today by Ashley Ball-Gamble, who is the Chief Executive at the Children's Cancer and Leukaemia Group, who's going to talk a little bit about the results and also what this means and the priorities for childhood cancer research. Ashley, I'm going to hand straight over to you, if that's okay.
Thanks very much for the introduction and for inviting me to speak today. As you've heard, I'm Ashley. I'm from the Children's Cancer and Leukaemia Group. So for those of you who don't know who we are and what we are both a charity supporting families and funding research, and we're the professional association and membership body for healthcare professionals, researchers and scientists working in the field of children's cancer in the UK and Ireland. So our professional association work includes things like education for professionals, networking, special interest groups, developing treatment guidelines and thinking about good practice guidelines. As a charity, we support families through information provision and some other support activities. And we have a number of projects looking at the speed of cancer diagnosis and a diagnosis experience for children and young people. And finally, we fund research across the cancer journey. So not only what you might think of as common sorts of research around discovery research and clinical research focused on treatment, but also things like supportive care and late effects. And we support families to raise funds for research into specific areas, such as the disease that affected their child. And we also bring together other research funding charities and share our expertise to support their research programs, so that we're making sure that the best research and researchers are funded and taking a strategic approach to research funding. So in what I've already said, you'll see that lots of the things I've talked about and the themes of our work overlap with the under-16 CPES. So I was asked to talk about what the under-16 CPES means to CCLG and how it links to our work. And I think it's really important to say that children's cancer services within and beyond the NHS really rely on collaboration with charities and the community of charities. And whether that's charity funded staff or charity provided information resources or charity funded research. So the patient experience reflected in the CPES results is a reflection on our contributions too, and the results really help us to ensure that we're spending our supporters' donations in the best way possible and meeting the needs of patients and families. So it's really good to see some really positive results, as well as understanding what needs to get better and where we can support those improvements. So we've long supported the concept of a cancer patient experience survey for children, and we've been pleased to be involved in the steering group for this work from before the first survey, and now in the Cancer Experience of Care Improvement Collaborative that's working on those projects that you heard about from the result of last year's survey. I think for us, we're also working really hard to better embed PPI in our work and thinking about patient and parent experience and voice across our work. And we're really quite good at this in research, but want to improve this in other areas. So for us, the CPES helps us to understand current patient experience and priorities for improvement, and it really serves to understand and embed the patient voice in our work across those various work streams, including the work we do around experience of care and information needs. So the results really feed into our work across CCLG, thinking about information gaps we can address or topics where we can provide education and support for our members, the doctors and nurses and other healthcare staff, and thinking about developing good practice to share. But today, really, I wanted to focus on research, and I think research is really key to help us better understand patient experience, including some of the issues that have been identified in the CPES results, and it gives us the opportunity to drive some of the improvements we'd like to see based on good quality research evidence. So first off, I'm going to share some of the top level goals from our research strategy as an organisation, and as I've said, we aim to fund research across the patient pathway and aim to fill some of the gaps supporting the types of research that it might be more challenging to find funding from other funding organisations. So we have a particular focus on things like supportive care and late effects. So we really aim to fund research that improves our understanding of childhood cancer, moves some of those discoveries from the lab to clinical practice, improves treatment or patient care, and this really includes experience of care, and think about the long-term effects of treatment with an aim to reduce and support the management of these. In our research, we also recognise the importance of collaboration, and we really believe that our position as both a funder of research and the professional association puts us in a strong position to help share and disseminate information and research, both within the scientific and clinical communities, but with patients and parents and families too. And things like our new research blog and the series of research webinars we started running for families focus on demystifying research and sharing it in a really accessible way. We've also just completed a really big piece of work that we started in 2019 and got somewhat held up by COVID, but that was the Children's Cancer Priority Setting Partnership. And we published the top 10 research priorities for childhood cancer. So a priority setting partnership with PSP is a piece of work with an organisation called the James Lind Alliance, and they're a non-profit initiative that bring together patients and carers and healthcare professionals to identify and prioritise unanswered research questions in a particular theme, and in this case that was childhood cancer, through a really robust and well-established process. So research priorities are often driven by the interests of researchers and the pharmaceutical industry, meaning sometimes what is most important to children, their families and the professionals who care for them might be overlooked. So these research priority setting partnerships really aim to shift setting the research agenda to patients and their carers and the professionals that look after them. So the children's cancer work was funded by CCLG and the Little Princess Trust, and our initial survey identified just shy of 1,300 potential research questions and topics from almost 500 respondents. The next stage of the process was to group together this huge number of questions so that similar questions were combined and out of scope questions were removed, and then a second survey asked participants to prioritise the remaining questions. Alongside this, we really wanted to make sure that children's voices were heard in the work, so we developed a series of animations and some special surveys, and finally a children's workshop to really make sure that children, and particularly young children, could participate in the work. And then the top 25 research questions from all of that work were taken forward to a final workshop to come to a top 10. And we've committed that our future research strategy will focus on answering these questions. So here are the top 10. Hopefully you can read those on your screen. I'm not going to read them all out, and I will put a link in the chat at the end, but I'll just give you a minute to look at those while I have a quick drink. So I have chosen a few the themes from the CPES report that we've heard about today to focus on and link that to research priorities and some of the current research work that's going on. So first, I'm going to talk about diagnosis experience. So we saw in the CPES data that 37% of families saw a GP 3 or more times with health concerns leading to a hospital referral, and that figure removes those who couldn't remember or went directly to hospital. So that's more than a third of families that saw a GP 3 or more times with symptoms that eventually led to a referral. And this story, unfortunately, is familiar to lots of children and young people's cancer charities and NHS professionals, and late diagnosis is really a concern for us at CCLG, and we know for families as well. And unsurprisingly, the PSP priority 4 reflects this, and that is about looking at research, asking how can we speed up the process of getting diagnosed and starting treatment in the right place. We know that more needs to be done to diagnose children at an earlier stage, and there's some tumour-specific research evidence that we're diagnosing childhood cancer at a later stage than some of our European counterparts. We also know that a later diagnosis can lead to increased burden of treatment needed to clear the disease, with then more long-term consequences. And this links into the top PSP priority, which is how can we find effective and kinder treatments for children with cancer. We did, in looking at the data, we did think the number of people having multiple GP visits before referral is a little bit at odds with some of the other data. And we've seen in the CPES that 80% of parents felt they were seen by a hospital doctor as soon as they thought it was necessary. So we know that public awareness of childhood cancer is low, and we're about to publish some research on public awareness. And we also know that primary care professionals and parents might not recognise the early symptoms. So while 80% seeing a hospital doctor quickly might make this look okay, and especially when compared to adult cancer pathways, we think the underlying concern about time to a referral into hospital from symptom onset paints a different story. But there's lots of good quality research well underway here. So the CCLG Child Cancer Smart project is developing some evidence-based referral guidelines for all types of childhood cancer, and this will result in tools for professionals and signs and symptoms campaigns for the public. And the childhood cancer diagnosis study is looking at the experience of diagnosis for, in an ideal world, that would be all children across a 2-year period, but as many children as we can recruit into the study in a 2-year period, thinking about their presenting signs and symptoms and their healthcare journey, how many times they engaged with healthcare before they got their referral into hospital. And this will give us a really rich understanding of the diagnosis experience and help us to learn where we can make improvements. I think this is really important because lots of NHS early diagnosis strategies so far focus on over 16s, don't really include children. So with some of this work, we're trying to influence change there. I talked about CCLG as an information provider, so some of the feedback about information was really important to us, and we know that 75% of families were able to find the information they needed about their child's diagnosis, and we'd like to hope that our information service contributes well to that, but there's clearly more to be done. And again, this links back to the priority setting partnerships 7th priority, and what are the best ways to ensure that children and families get and understand the information they need in order to make informed decisions around the time of diagnosis, and then during treatment, and at the end of treatment and afterwards. Information provision is always evolving. We're supporting some new research at the moment on decision-making tools to parents and clinicians, and as I said earlier, thinking about research blogs and looking at developing information in new accessible formats, including some video content. Thinking about life after treatment, we know that around 2/3 of children will experience at least one long-term consequence of their treatment, and 1/3 of these will experience multiple complex and life-impinging or life-threatening consequences from their treatment. And that's before we start talking about the complex social and psychological and mental health impacts of treatment as well. So in CPES, we saw that from those who have completed treatment, which was 403 respondents, 43% reported that only to some extent or they did not receive enough ongoing support from the hospital after treatment ended. This really ties into priority number 8 from the priority setting partnership, and that's around the impact of cancer on the lives of children and their families after treatment and in the longer term, and what are the best ways to help them overcome these impacts and to thrive and not just survive. So within CCLG, our late effects group is a network of professionals that specialise in late effects. We've recently launched a new information pack for survivors, tying back to the information theme. And over the last few years, we've awarded a number of late effects focused research grants. I think a really important focus for research here is how we can deliver effective risk stratified follow-up care, both immediately and in the long term. And long-term care and support is something we recognise in the charity sector as a gap. And lots of our own support services tend to drop off post-treatment. And I think the bottom line is that's a resource issue. Thinking about how we can provide the right support services to the tens of thousands of survivors now, and a number that's increasing each year, is a real challenge, and one that we hope research will start to address. CPES has identified impact on children's schooling, and whether that's through them being too unwell to attend school or having a busy schedule of treatment appointments, whether that's through fatigue or poor concentration or other side effects of treatment. And again, thinking back to the priority setting partnership, this ties in with a couple of priorities. The one we've previously looked at around impact on the lives of children after treatment and returning to school. And also thinking about the relationship between chronic fatigue syndrome and chronic pain and treatment for childhood cancer, and how that affects children's ability to go to school and engage at school. Again, we've got some current research projects underway here, one around understanding the challenges of living with treatment-related hearing loss and the impact on education there. And another project is a comprehensive scoping review that's looking at what's been published so far for healthcare and education professionals to help children with cancer continue with learning. And a project like this can help raise awareness of the issues and suggestions for what's helpful, as well as start thinking about identifying areas for further more in-depth research. I was particularly interested, all of the results are interesting. I was particularly interested in some of the qualitative feedback from the survey and some of those issues that recur frequently around having things to do in hospital, access to Wi-Fi and play, access to appetizing food, and the ability to get a good night's sleep and find some quiet time. And this really links back to priority setting partnership, priority number 6, which is around how we can make being in hospital a better experience for children and young people. This is one where I think there's a real research gap, but there's a strong message about improving the experience of care for children, and a real opportunity to think about what research we need to do and use research to develop a good evidence base on which we can improve experience, improve Wi-Fi and play and appetizing food, and do that in a way that's based on good quality research. So that's a real priority for us now, thinking about how we can plug that research gap and the sorts of project we can support. Lots of comments in the free text section around food and financial burden. Some of this might be alleviated by care closer to home when it's clinically safe to do so. And that ties into priority setting partnership priority 9 around making some treatments accessible closer to home in shared care hospitals. And again, we have a shared care group in CCLG thinking about how we can educate and support professionals working in shared care. And we've just established a new ambulatory care network that's going to bring together professionals who are interested in offering services that might let children have infusions at home or in settings outside the hospital. And we're currently looking at research projects in this area. So I hope that's given you a flavour about how we might use CPAS in our work at CCLG and where research is addressing some of the current issues as well as future plans for research. I really think that CPAS is a valuable resource that helps us to understand where improvements can be made in the work that we do, whether that's supporting our members working in the NHS with education resources, with tools, with support, whether that's supporting families with appropriate and timely and accurate information and support services, or whether that's informing our research priorities. And we're actually, in this case, really reinforcing our research priorities because of the synergies between the research priorities and the CPAS results, and helping us to identify particular gaps where research might be more urgently needed, particularly thinking back to food and Wi-Fi and sleep and patient experience. I think that CPAS is also a really important tool for charities in supporting our insight work and developing our strategies and future service developments, and also really helps in putting patient voice and experience in the heart of our work. I'm really interested in continuing this conversation with people that are interested. If it's time, I can take questions, but that's my Twitter handle and email address, and just some links to some of the resources that I've talked about over the last few minutes. Thank you very much.
Thank you so much, Ashley. A very powerful set of priorities that you have listed there, and some really interesting programs and projects that you've got in the pipeline there, or currently working on. Thank you so much for joining us today. Neil, I'm going to hand over to you, if that's okay, to close us out for the session.
Okay, thank you very much. Ashley, I was going to ask what happened to the pink hair, looking at your Twitter handle.
Old photograph, maybe I should update that.
It was rather good. It was rather good. Anyway, thank you very much, everybody, and really enjoyed listening to the presentations. I think just a few concluding remarks. I think first of all, just to note, there's a lot of positives in what we've heard, and I think I've spent the last few months looking at what people have said about different aspects of NHS care, and some of the findings here are definitely at the top end of people's experiences. So some very positive things, and it's great to see what's valued and to be able to build on those things, and things like play, for example, coming out really strongly in the work that nurses do. Of course, there's more to do, and we've heard a few pointers here. I think one of the things that I always encourage you to do is just to look into the differences between different groups of people, whether that's differences in terms of children and young people with different types of cancer, or differences in relation to age cohort, the younger children and the teenagers, differences in relation to ethnicity. It's always really helpful to try and understand what's behind those. This is one of the beauties of the survey, because it gives you lots of places that you might want to inquire and ask further questions, and when you do, there will be lots of interesting feedback about why people have said certain things, and what matters to them. And I think one of the beauties of working with young people is you always learn something new when you talk to them about what matters. I was talking to a group of young carers recently about how they thought they could raise awareness of the issues that young carers face, and a lot of the ideas they had on digital went right over my head. It was fascinating. It takes me at least 2 years to catch up with the kind of things that they talk about and do. So I think the what we really encourage you to do, if you haven't already, is just to put these findings alongside any other forms of insight that you've got in your services. Look at what people are feeding back in terms of their real-time feedback. Look at the notes that people are leaving, notes of praise, any complaints that people have made, and just any other data sets that you have to evaluate this data against others. That's always really valuable, and to try and use these findings to spark conversations at all levels, whether that's at a commissioning level, hospital level, Cancer Alliance level, with voluntary sector, with children and young people, with parents. I think those conversations are hugely valuable and tend to be the things that drive improvement. And I don't know what your reaction to that. I would have loved to have heard people's reactions to some of these findings, but certainly they chimed a great deal with me. We had a young woman come to give her story to our NHS England Board Quality Committee recently, and there was a lot that she could have talked about in relation to her care, but the two things that she wanted to talk about were access to play facilities 7 days a week, and making sure that her mum got food. Those were her two priorities that she wanted to leave us with, or leave the NHS England Quality Committee with. So it's interesting to see those findings represented here as well. So I think taking Ashley's point, that there's some fantastic support and resources available in the voluntary sector, and that those links are really important to make. I think one of the reasons that we've seen year-on-year improvement in many aspects of cancer care has been the dedication of the cancer charities working alongside colleagues in the NHS, both in terms of understanding things better, producing tools and resources, helping to support staff, helping to support research. So please do take full advantage of that. But I think the biggest message from us really is just the benefit and the enjoyment of working alongside children and young people, working alongside parents in bringing about improvement and change. They will have fantastic ideas. They will have ideas that we haven't thought about. They will help to explain why some of the findings as they are, and things that can be done about them. And often we do find that those ideas are really practical and often a little bit cheaper to implement than we might have thought, and certainly some of the ideas that we might come up with ourselves. So that's the benefits of working in co-production and making sure that as we do that we're involving and listening to people from all parts of the community, so we understand the differences as well. But it's been very interesting to hear today. I really look forward to seeing what you do with the data year on year, and how this fits into your improvement journey. But it's really good to be here today listening with you, and good luck. And I look forward to hearing your stories and improvement journeys in future. Thank you.